we just finished a really exciting session showing the next, latest and greatest for tumor-infiltrating lymphocytes in solid tumors here at the iwCAR-T meeting 2026 here in Tampa, Florida. And I think our panelists today, each of them gave important talks introducing what this is going to look like in 2-3 years. And so I'd first like to introduce Dr. Rodabe Amaria, who presented on from MD Anderson on OBX-115, Dr. Lilit Karapetyan from Moffitt Cancer Center, and Dr. Dan Olson from University of Chicago. So really, wow, what are you guys' takes from today? I know that we've kind of been addressing a lot of different problems that we see in tumor-infiltrating lymphocytes, right? 30% response rate, 20% response rate in some of the other tumors. How do we do better? And I think each of you maybe, addressed some of the problems we face, right? Gene editing, right? Going back to the lab to find out, how can we improve on this? And then Dan, going earlier, right? Going earlier, and what approach do you think is going to win in the short term?
Well, I mean, I think that's debatable, and I'm not sure, if win is right word, right? I think it's important to have multiple different approaches at one point, all sort of going on in parallel. I think there's been a lot of interest in modifying TIL, and there's different ways to modify TIL, right? You can do viral vectors to gene edit, you can do CRISPR editing. There's a variety of different ways that you can approach that. So I think those are very important. I think a lot of times when you're using these, very experimental things, you're going to go into the heaviest patient population for need, which is going to be treatment refractory. Only once you can prove that your therapy works, it's effective, it's safe, then I think you can then kind of shift how, in the paradigm, where in the paradigm you actually offer that therapy to.
And so this concept of, like you said, you presented completely IL-2 free TIL infusions. I think that holds a lot of promise, I think, for us. Is there a possibility to do a dual IL-12, IL-15, IL-18, IL-15? Do you see the possibility of like adding even more armoring to our TIL that we use in clinic? Obviously, you're showing a lot of promise with the OBX-115. It's just one.
I think we learn a lot now from what they're doing on the CAR-T side, and you're seeing these incredibly complicated CARs with all different kinds of armors and targets and things that they're doing. I think right now we're not quite there in solid tumors. I think we're trying. I think we need to pick a problem and try to figure out how to best solve it without not necessarily doing too much at once. I think the OBX model does allow for an exogenous cytokine-free environment, which I think is safer and expands the pool of eligible patients. And that's a good starting point, but there's certainly a lot of work left to be done.
And I think that exquisite control you have of being able to add the citazolamide and stop it, which activates or deactivates the product.
So you have an inducible and a regulatable TIL, which again, learned kind of from CAR-T, having a kill switch, right? Well, this isn't exactly the same thing, but you have the ability to turn the cells on or turn the cells off, which again, allows you as the physician to really control at an individual patient basis. If patients are having issues, you can always back off. If patients are doing fine, they can continue on with the regimen. But again, the whole point is to enhance patient safety, which makes for more potential eligible patients.
I think the analogy I heard is that when we give IL-2 to a patient, we're basically flooding the hallways with caffeine. And if you give them a gene-edited, recombinant cytokine, membrane-bound, you're basically giving each person their own cup of coffee. And you get to choose who gets to be, and when they're activated, they get to take a sip or not. But if the hallways were flooded with caffeine, we'd all be burned out, right? And zonked out. And that's what happens with conventional TIL, right? And so Lilit, you were showing that the PD-1 ICI patients had a much lower amount of central memory T cells.
Right. I think what was really good for our cohort of patients, we had a lot of patients who received immediate ICI before tumor harvest. Some received as part of a trial, others before trials. And what was really important to highlight that stem cell memory cells, which, as you know, although described with a different phenotype by other groups, have a role importance with a durable response. And they definitely decreased. Also, impact on functional activity like co-stimulatory signaling was really interesting to observe that it was clearly diminished in that prior ICI. I think that's an important argument when we sequence the therapies, especially nowadays. We have approved combination therapies and using those in a neoadjuvant setting, and then patients have advanced melanoma is maybe an important piece of data to think when we introduce new line of therapy in the advanced setting.
Yeah, well, friendly in lung cancer, we're just now getting on board with neoadjuvant, but but I think the profound thing was that I think even if we look back at the original LU1202 trial, the patients who were on less doses of immune checkpoint did better. People who were on it for more than 6 months, maybe they had less of those stem cell cells, right?
Right. In general, even with the real world data that we looked with the TIL, I think lines of therapy definitely matters.
And duration.
And
right.
then that's
Yeah.
true.
Yeah.
The only caveat would be sometimes I also think about those patients. If someone is has a melanoma, has so many lines of therapy, is so durable, then that patient probably has good disease biology as well. That's one small caveat,
Right.
rather someone who is progressing from first-line therapy.
But actually, lower duration of ICI had more response. That was the surprising thing, I thought. So it
I think the sequencing thing is a huge
Yeah.
deal in melanoma especially, right? Because we do have frontline ICI that can potentially durably benefit maybe 40% of people, and so I think it's a little bit hard, in my opinion, to say we need to be doing TIL earlier and early. I agree we shouldn't be doing TIL 6th-line therapy. Maybe we shouldn't be doing 4th-line. Maybe the sweet spot is 2nd-line. It's a little bit hard in my mind to square it completely frontline just because we do have effective ICI options. I think if you're looking at it from a socioeconomic standpoint, though, you could say one-time TIL therapy might be a lot cheaper and better quality of life than 2 years of an anti-PD-1 based therapy. So I think that is a viable approach, but I'm reluctant to say that it should be frontline for everybody.
Yeah, I think the debate is really in that 2nd and 3rd line. I think we have a lot of evidence to suggest that it's really hard to get patients to TIL therapy beyond that. And certainly the way that the label's written right now, that it's BRAF experienced, I think that's a challenge, because that means for a lot of people who are not always thinking about the sequence or their usual tools or PD-1 antibodies and BRAF, that they're treating a maximum response and then trying to send the patient to a TIL center, because more than 60% of patients treated with melanoma are not treated by academic doctors. They're sending these patients at a very different stage. And so I think there are clear things we can do from a messaging standpoint to say earlier is better. If you're starting BRAF therapy, you should start the TIL referral, hopefully. And we can think about ways to get patients procured or take a treatment before they're fully resistant, because we just want to not leave anything on the table. So I think there are, certainly practical things that we can do to increase the likelihood that more people get treated. But at the same time, we're hoping to, develop better therapies. The gene-edited TILs and, phenotypic selection of TILs is all really interesting. Ben, maybe that's a question for you is, we talked about the challenges of neoantigen-selected TIL, and there's companies that have tried to do that. Those companies aren't around anymore. I think they showed it was, a big challenge. And so we can use these surrogate markers for phenotypic selection. Can you talk about the logistical complexity of that? How does that compare to neoantigen? Like, if I was a company trying to start saying, I want to make a better TIL, and if that was my strategy, what would it do in a nuts and bolts kind of way?
Yeah, so I think the Rube Goldberg idea of synthesizing neoantigens, predicting them, genomics, takes, as we say, 4 or 5 months sometimes, just is not feasible in real practice. But these surrogate markers, you're enriching, let's say, 2-fold, 5-fold, 10-fold the amount of antigen reactive cells in that initial culture. I think that is a very viable method, and that maybe one of the promising ones is the one that was presented in the Netherlands, showing that tumor clusters using using cell sorting for CD146 really allows you to select those T cells that are actually right there associated with tumor physically. And if that can be put into a trial, you better believe I would be very excited about seeing how well that would perform. That being said, sometimes simpler is better. And I think over the last 5 years, we've surprisingly stuck with bulk TIL without actually doing a lot of elaborate methods at this point. Going back to that same question, that theme of referral patterns, right, which we all face. So let's say the phase 3 trial is positive for LE1202 in melanoma. Are community physicians going to be referring to University of Chicago for a newly diagnosed melanoma patient? And how will they start a little pembro beforehand? And are you going to be trying to resect a rapidly shrinking tumor?
Yeah. No, it's a good question. I think we won't really know until it maybe happens. My suspicion is that the routine patient will not get referred for TIL early. It's not how the incentives align in the world. And so, I just don't think that that's realistic. So I think it will be for the highly motivated patient who is trying to hit a home run, at the first swing. I think that's the idea. So that makes sense for some people. And, sometimes the arguments we've laid out that, one and done or not, don't want long-term exposure to multiple therapies. I really want to take my best shot first. That might be the right fit for some people, but I think those are going to be the people who are plugged in or, happen to be treated in an academic center, and that makes sense. But sometimes where you are and what your options are is going to determine what you get. And I think that's just the reality of the landscape.
Yeah. And so I think an interesting point was that Dr. Miklos mentioned, in our TIL area, we don't put in a genetic marker so that we can track the TIL over time. But, as I think several of us said, we've seen that we can track the TCR, the barcode on the T cell of what gets infused in patients over time. There's this theme, right, that persistence is important. And having the ability to use the acetazolamide as an inducible way of reactivating the TIL seems like a really attractive strategy. The idea of vaccination against neoantigens, which hasn't really been fully fleshed out with TIL and melanoma yet, is something that also is a great way. What are you guys' take on how to solve that persistence problem?
Yeah, I think it's tough to know for sure. The Obsidian approach is interesting because, again, you can kind of reactivate. We think we're reactivating the OBX cells by repulsing them with acetazolamide. It's a little bit hard to prove that. I think, like I said, it would be helpful to have serial biopsies to be able to figure out that we're actually making these cells and they're going into the tumor and affecting killing. So it's a little bit hard to know. I mean, certainly we can track these cells, these engineered cells in the blood pretty easily. And again, what becomes a challenge is getting those numbers out over time. But I think, we can see evidence that these cells persist. But as you know, it's a very small subset of the actual bulk infusion product. And so it ends up being a terribly inefficient system with weeks and weeks and tons of money to expand out these cells. But as it stands right now, I think in the absence of better technology, that's kind of where we are. And the beauty of the science is that whatever 1 or 2 clones or 10 clones that's working in patient A is going to be completely different than what's happening in patient B. And that becomes really, really challenging to be able to understand and to figure out a way to focus just on those clones, because those clones are going to be different for patient to patient.
Yeah, and I think too, it's really interesting how advanced the science is right now and a lot of the questions that we're asking. For example, looking at the different phenotypes and what associates with these durable responses, and we're just discovering that, but at the same time, there's so much that we can do. And so there's so many questions that we're asking and we're just characterizing it. And the ability to manipulate the TILs ex vivo or, the engineered cell therapy, there's so many different things that we can do. That gets really interesting, like what are the different gene editing techniques? And then at the same time, we have to think about what's practical. And so it's one of those, like, perfect, the enemy of good. And there's so much we can do, but sometimes when that happens, you end up extending the manufacturing process so long that it's not practical. And so there might be these intermediate states where you look for the right approach and say these phenotypic markers that we can do relatively quickly. Maybe that gives us something better, and that's a good compromise. So it feels like the Wild West. There's so much you can do, but how much should we do? What's realistic? Those are the important questions. I don't have all the answers to that.
I face this question all the time, which is, I have a lymph node, I have a liver, I have a lung. Oftentimes I just have one area to do for surgery. Are we selecting certain areas over others for TIL resection at this point? I know, aside from operational reasons, would I prefer to reach for a lung tumor or a lymph node? Any thoughts on that?
I mean, I think Iovance has the dogma that maybe, lymph nodes are better to serve as a starting material. Maybe the liver is not as good, but I really think that's center dependent. If I look at the data from my institution, we actually harvest a lot from the liver because we have an excellent surgeon that can do these surgeries in a minimally invasive way. I think we've had very few out of specification. So I really do think it's going to vary center by center, surgeon by surgeon. But no, I'm not sure. I think besides the lymph nodes, which we all think are probably the best places, I'm not sure if there's a key second place that you should be going for. You guys?
Yeah, and I think the lymph nodes are good for generating a product that meets quality specifications. We don't know which one necessarily influences the outcomes. And so is an inspect product from the liver different than an inspect product from the lymph node? Those are questions we don't know yet. So we'll have to answer those hopefully with real world data.
Of which I think where the real world data is coming out, like you say, is there's like a threat. Is there a threshold of cells maybe around that 40 million or 30 million? Is there, all other things being equal? Or do you think it's more just the random black box, the percentage of antigen reactive cells that happens to be in there? I'm not sure.
Yeah, I think in terms of cell count, as I was showing in the figure, specifically for TIL persistence and durable response, I do believe there is threshold matters. So, and I've seen that even in a real world lifileucel patients. But as I was alluding to that, it is not necessarily linear, like higher will go is always better, but definitely there is a threshold that we need to meet. That's what I believe.
If I was understanding your data, was the first quartile where it didn't seem to work as well, but higher, it wasn't quite as distinguished?
No, it's different.
Got it.
And if even with the Iovance data that reported with real world, it was not different, but their numbers were very similar, like 20 to 30 billions of cells. But of course, we are talking within a spec product.
Right, exactly. Yeah. And certainly in our experience for lung, we did have some patients that had relatively few cells infused, maybe 5 million or something, and they did not respond. Whereas some patients had 150 million.
Yeah.
Rhoda, your initial patient on OBX-115, amazing, multiple disease sites. You just know when you see that, right? The patient's having the CRS, they're having the edema in the brain, basically like a TENS kind of syndrome. And you see the lymphocyte count went up to 30,000.
Yeah.
First, have you guys seen this as well? Like the patients with a higher lymphocyte count, it's like antigen-driven expansion of cells in the body, right?
Yeah, I had never seen it before this. And I still think that there are some people with that product that are the exceptional responders that really do have those same kinetics, maybe not as high, and maybe not 30,000 absolute lymphocytes within 5 days, but there is a subset of those patients that actually expand amazingly well. And the problem is you can't figure out who those patients are at all. It seems completely random, but absolutely those patients with that kind of exponential initial engraftment period, they seem to do the best long-term and have, durable response without needing any, additional therapy. It's just crazy because we can't figure out who they are.
Well, thanks for this, quick chat, this little huddle after our presentations. Excited to see what the rest of this conference will hold on Solid Tumor Day today with CARs for solid tumors, TCRs, TIL. We'll see bispecifics later on tomorrow. And thanks for presenting on this really future of cell therapy. Thanks.